Hi everyone, thank you for coming to our presentation. And this is the best practice for surgical dehisced wound healing. This is brought to you by Tom Miller, Josh Connolly, Eva Howard, and myself, Tom Storm. So we researched the best practice for healing surgical wound dehiscence with secondary intention, and what we found was that negative pressure wound therapy would be the primary focus of our searches. Surgical wound dehiscence is a serious complication of the post-surgery healing process. It can result in longer healing times, increased patient morbidity and mortality, and an increased cost to the patient and hospital. People with surgical wound dehiscence, healing by secondary intention are the main population of problem we were looking at. Some current procedures include standard wound therapy, wound flaps with the Regenera protocol, and negative pressure wound therapy. So for wound to heal, 4 elements must occur simultaneously, and that's hemostasis, inflammation, proliferation, and remodeling. All these must occur simultaneously and uninterrupted, or it can result in longer healing times. So how do these surgical wounds dehisce? Any movement or straining in or around or under the wound can cause a wound disruption to occur, and the likelihood of a wound disruption occurring is increased with ischemia, infection, diabetes, malnutrition, smoking, and obesity. It's important to teach patients, providers, and nurses the red flags of a wound disruption so that they could be assessed and treated early, especially for the patient at home. So anything like an increase in drainage or bleeding at the site of the surgical scar can be an indication of a wound disruption. So how do surgical dehisced wounds heal? Well, oftentimes they're left open to heal and will heal from the bottom up, and this is called secondary intention. Surgical wound dehiscence has a number of effects on the patient, notably an increase in pain and discomfort with movement. A number of psychological changes can occur as well, like a change in body image, anxiety, stress, fear, frustration, and depression. These patients might experience like lost time and lost ability to work, which can result in lost income and contribute to those psychological effects. And this also has an impact on the healthcare system as well. Surgical wound dehiscence can contribute to an increased use of staff hours, wound care supplies, and if a wound disruption occurs during the post-operative global period, a lot of the care for this wound will not be reimbursed to the hospital by insurance companies.
And then we came up with the problem statement of dehiscence of surgical wounds is a serious postoperative complication associated with high rates of morbidity and mortality. In the U.S., 0.5 to 3.4% of people are impacted at an average cost of $40,000 in excess expenses, and depends on factors such as insurance, severity, and treatment for the wound. And then our PICO question is as followed: in dehisced post-surgical patients, what best practices or strategies compared to current practices affect healing? And then for our search strategy, we concentrated on keywords like best practice, current practice, surgical wound dehiscence, complicated wounds healing time, secondary healing, and secondary intention. And with those keywords, we gathered our information from databases like CINAHL, PubMed, and Cochrane Library to come up with 12 articles.
Using the search strategy that Evie mentioned, we each analyzed 3 peer-reviewed articles for a total of 12 articles. 3 of our articles were level 1, the highest quality level of evidence. The level 1 studies consisted of systematic reviews of random controlled trials or case studies and are shown in the parentheses. The remaining articles ranged from level 2 to level 5, with most of them being level 4. There were many techniques discussed in the literature regarding healing dehisced wounds by secondary intention. As you can see from the interventions table, the top two treatments were negative pressure wound therapy and standard wound therapy. Standard wound therapy includes non-adherent dressings, wound packing, and wet to dry dressing changes. Negative pressure wound therapy was the most discussed treatment in the literature. This technique has the potential to substantially improve wound healing, reduce infection rates, and reduce hospital stays. Since the majority of the articles discuss the benefits of negative pressure wound therapy, we created two outcomes tables. The first table includes outcomes for techniques that did not involve negative pressure wound therapy. Most of these treatments showed a positive advantage. Negative pressure wound therapy also showed mostly positive advantages. However, a couple of the studies did demonstrate an increase in adverse events. The studies that found an increase in adverse events saw the formation of fistulas. However, a meta-analysis of 48 random controlled trials did not find any change in morbidity, mortality, or adverse event rates. The cost and availability may be the biggest barrier to the routine use of negative pressure wound therapy. Standard wound therapy remains an important and effective modality, but can be slow, prone to infection, and complex to manage. In a qualitative study, interviewed surgeons and nurses considered negative pressure wound therapy a favored treatment modality despite a lack of research evidence backing its effectiveness.
So based on our body of evidence, we recommended intervention for treating negative pressure, or for treating surgical wound dehiscence is negative pressure wound therapy, or NPWT. NPWT uses a vacuum-assisted dressing to remove fluid, reduce swelling, and promote the growth of healthy tissue. As nurses, we're responsible for the wound assessment, applying the dressing, ensuring the vacuum system is working, and changing the dressing every 48 to 72 hours. Prior to proper training and strict infection control are key to preventing complications. This therapy involves a collaborative team. Wound care specialists guide the treatment. Surgeons oversee any surgical needs. Infection control manages infection risk. Dietitians support nutritional healing, and physical therapy or occupational therapy help with mobility and pressure relief. Together, this team approach makes negative pressure wound therapy a highly effective intervention for promoting wound healing. One of our clinical experts was Sam Musser, the provider from the St. Joe's Wound Care Clinic. We chose Sam because she has a history of treating complicated wounds as both a nurse and as a provider. This gives her a unique perspective in the process of both ordering and managing negative pressure wound therapy pumps and the wounds.
Our other clinical expert was Gabe Keynes. He works at the Tri-State Wound Care Clinic, and he had a lot of valuable insights into how surgical wounds heal. He told us that a lot of providers will use outdated wound care techniques to heal the wound, and oftentimes a lack of training and confidence can prevent the use of advanced wound care tools. He told us that a lot of times nurses on the med-surg floor will call upon nurses on the wound care clinic to troubleshoot or put on an advanced wound dressing, like what we've seen with the negative pressure wound therapy. And what we've pulled from this was that education was the most important thing we could focus on for our project, and helping healthcare providers and nurses have more knowledge about this type of therapy, and that it's actually individualized care is favored over protocols due to the standards by Medicaid and how the hospital is reimbursed. The care can't be like a cookie cutter type of deal. It's got to be all individualized for the hospital to be reimbursed, and Patients will often return to the clinics because of their chronic conditions like diabetes, and also non-adherence to the care plans can contribute to returning patients. So our recommendation, we're focusing mainly on the education aspect and the awareness part. We'd want to, tell all the providers and nurses that this modality of healing a wound can contribute to a decreased patient morbidity and mortality and a decreased overall cost to the patient and hospital.
For our deliverable, we came up with a flyer that has common issues and troubleshooting for the devices. The flyer has common alarms, steps on changing the canister and changing the hose, different suction settings, and websites for the KCI and Nexus machines that give more information if needed.
Some common barriers for negative pressure wound therapy. One is the wound characteristic and location. NPWT is not suitable for all wounds. Wounds with exposed vital structures, untreated osteomyelitis, or active bleeding are contraindicated. Also, wounds that are in difficult locations, such as the genitalia, perineum, or on weight-bearing surfaces can pose challenges for device placement and maintenance. Also, there is a barrier because of pain and discomfort. Patients may often experience pain during negative pressure wound therapy dressing changes, potentially leading to non-compliance. There's a level of inconvenience to carting around this little pump. You have to sleep with it, you have to remember to charge it. There's an added noise and possibility of alarming due to a failure of seal or low battery. There's a perceived complexity. Some clinicians believe that negative pressure wound therapy is complex and time consuming and requires specialized training. Even though there's a cost barrier as well, initially, especially with those without insurance, starting negative pressure wound therapy can be a little costly. Implementing negative pressure wound therapy as a best practice treatment for surgical wound dehiscence aligns well with the quintuple aim in healthcare. It improves the patient experience by reducing pain and discomfort through thorough dressing changes. It improves the population health by promoting more effective wound healing by reducing complications like infection and extended hospital stays. It reduces costs. Even though it may have higher costs up front, it can reduce overall healthcare expenditures by shortening hospital stays and readmissions. It improves the provider well-being by simplifying wound management. It allows for fewer dressing changes, which reduces the nursing workload. And it also advances health equity. When negative pressure wound therapy is broadly accessible, it ensures high quality wound care regardless of the patient demographics. The Minnesota Public Health Wheel is a framework used to describe and guide public health nursing practice. The purpose is to standardize and define public health interventions, clarify the role of public health nurses, support evidence-based practice by providing consistent language and structure for interventions, and promoting population health by targeting the root causes of health issues rather than just treating the symptoms. As you can see, we focused mostly on advocacy, collaboration, and health teaching. The change theory that we chose to use is Lewin's change theory. This is a simple and widely used model for understanding and managing change. It has three key stages: unfreezing, which is preparing for the change; changing, which is implementing the change by introducing new processes, behaviors, and thinking; and refreezing, which is stabilizing the change by reinforcing those new behaviors and making them part of the culture or routine. The goal is to help individuals or organizations transition smoothly and sustainably from old practices to new. Along with this change theory, Lewin proposed that there are driving forces and restraining forces for change. Some of these include increased demand, pressure from leadership as driving forces, and restraining forces such as organizational culture, comfort, and past unsuccessful change initiatives.
Considering implementation in a hospital setting in the view of Lewin's change theory means we must identify the need for change. Standard wound therapy is important, but as we noted previously, it has its drawbacks. Recognizing the limitations of standard wound therapy can create dissatisfaction with the status quo, initiating the unfreezing process. The benefits must then be identified, such as reduced risk for infection, sealed wound edges, controlled exudate, and better tissue granulation, which can lead to faster healing and less time in the hospital. Unfreezing needs to involve addressing concerns such as adverse events or cost effectiveness. Identifying these concerns allows an open discussion to understand the benefits and limitations of its use. Change involves the actual implementation in the hospital. The most significant part of the change phase is providing adequate education and training. Structured and ongoing training programs should be created to educate the staff on the principles, application, troubleshooting, and potential complications. Clear policies and protocols for initiating, monitoring, and discontinuing treatment need to be formed. Supply managers will need to develop systems to assure the facility can obtain all the necessary components of the system, including mechanical units and disposable supplies. Biomedical managers will need to develop systems to maintain the new equipment and repair it as necessary. Refreezing is where we make negative pressure wound therapy an accepted and routine part of the wound care system. Negative pressure wound therapy should be considered during wound assessment and management phases. Data collection can help assess outcomes, identify areas for improvement, and demonstrate value. Adoption can be reinforced by sharing feedback with the staff. As more evidence becomes available, it's important that protocols be adjusted to reflect best practices. When considering a therapy, the 4 pillars of ethics must be considered. The patient should understand the risks and benefits, as well as alternative treatments, and be allowed to guide their own care. The patient's ability to provide self-care should also be evaluated to assure the treatment does not limit their autonomy. Accelerated healing and reduced infection rates are a couple of the perceived benefits. However, despite the perceived benefits, there remains a lack of strong research evidence indicating a clear clinical and cost-effective benefit. This raises the ethical question about whether the potential benefits are truly substantiated. Adverse events such as fistula formation should be considered during the planning phase. Although the patient may experience fewer dressing changes, removal of the dressing and the foam may be more painful. So careful patient selection and ongoing monitoring to detect and manage potential harm should be implemented. Risks and benefits should be weighed against those of alternative treatments, such as standard wound therapy. Cost effectiveness and limited availability may raise concerns about the equitable use of healthcare resources. Efforts must be made to assure availability based on the need and not the location or socioeconomic status.
We recommend that this teaching on negative pressure wound therapy be instituted in the new nurse training that every nurse goes through when they get a job at the hospital, and then also yearly update training. To disseminate our deliverable, we recommend that this troubleshooting resource be placed on the hospital intranet, and then also be referenced when the wound care clinic teaches the new nurse training and the the wound care continuing education classes, new nurse orientation, and the annual refresher wound care training. To evaluate the effectiveness of this deliverable, we will count the number of times our resource has been accessed on the hospital intranet. In addition, we will work with the wound care staff to determine the number of requests that they have received over the past quarter for the initiation of a wound vac system or for the maintenance of a wound vac system and the associated wound. We will then compare that number of clinic interventions requested in the quarter following our education initiative.
Based on our research, the best treatment for surgical wound dehiscence is negative pressure wound therapy, and we also found that there's a lack of education when dealing with wound vac devices. And then for my aha moment, I thought that it was interesting that you have 2 hours to reinforce the dressing if the seal is broken, or you have to change the whole dressing.
As a first assist, I applied a lot of these systems on patients. It wasn't until meeting with Gabe and Samantha that I realized that someone other than the surgeon or their PA became responsible for maintaining or troubleshooting the dressing once they left the OR.
My aha moment was that nurses and healthcare providers alike will continue to learn throughout the profession even after graduation.
And my aha moment came after working for a summer with Sam in the wound care clinic when I was able to install and maintain about 100 of these negative pressure wound therapy dressings. There's a perceived complexity, but it's actually quite simple. These are our references. And are there any questions?